Assalamu alaikum. I'm Dr. Maram Bayat, consultant radiologist in women's imaging. In our efforts to promote breast cancer awareness, I will be talking about screening mammogram, in particular, understanding your mammogram report. As you may know, breast cancer is the most common cancer in women, not only in Saudi, but also worldwide. Though we don't know a single cause for breast cancer, it is believed that the interaction of many factors together produce cancer. I'm not going to talk too much into the details, but I'm sure this topic is covered by others during the series. There are many factors which you can't change, unchangeable, uncontrollable factors. For example, gender, simply being a female, increases your risk of breast cancer. Here I'll mention that men can also develop breast cancer, but much less than females. 1% of men develop breast cancer compared to 30% in women. Another uncontrollable risk factor is genetic predisposition and family history. If you have certain genes, the most important or the most common being the BRCA genes, BRCA genes, which puts the patient at a higher risk. Similarly, if you have strong family history, that's first-degree relatives, mother, sister, or daughter, would also put you at a higher risk. Other risk factors can be controlled, and by reducing these controllable factors, you can decrease the risk of breast cancer. For example, decreasing the body weight, increasing physical activity, and decreasing hormonal use, either oral contraceptive use or hormone treatment for menopausal symptoms. You can also reduce the risk by increasing protective measures, such as regular breast examination, either self-examination or annually by a physician. The most important protective measure is the topic of our lecture, compliance with regular yearly screening mammogram. Now, mammogram is an X-ray of the breast. It uses low radiation dose. We usually do 2 views for each breast, a total of 4 views per mammogram. Now, when we say low dose, to bring it into perspective, it is slightly more than a regular X-ray, but significantly less than a CT scan or cross-sectional imaging. Now, to put it another way, think about it as if getting a mammogram, the radiation you get from a single mammogram is equivalent to the amount of radiation from background radiation, the radiation that that's in the environment. Okay, so anyway you view it, it's a small dose of radiation, and its benefits outweigh the harm. So mammogram is either screening mammogram or diagnostic mammogram. Screening mammogram is done for asymptomatic females. The aim of screening is to detect breast cancer in its early stages before symptoms appear, when treatment is most successful. Now, mammogram by itself will not prevent breast cancer, but it helps finding it earlier. We recommend yearly screening mammogram for women starting at age 40, and this is for average risk women. Here in Johns Hopkins Aramco, we use both 2D and 3D views. Mammogram is the gold standard and cannot be replaced by another exam. It can be coupled with complementary studies. For example, a mammogram can, in addition to ultrasound, can be done for women with dense breasts. An MRI can be added to a mammogram for screening in high-risk patients, those with a lifetime risk of over 20%. Usually those with genetic mutations, like we mentioned, the BRCA genes, and those with first-degree family history. So for those patients, we also start the screening at a younger age, younger than 40. Okay. Now, the second type of mammogram test is a diagnostic mammogram. This is for patients who already have symptoms. symptoms such as palpable lumps, nipple discharge, or skin changes. Or in the case of an abnormal or incomplete screening mammogram. Depending on the age, if the patient is younger than 40, we usually start with ultrasound. And often we find benign findings, findings that don't need further imaging or follow-up. But if we do find something that's suspicious, then we would add a mammogram. But for patients who are above 40 years of age, we automatically right away do the mammogram and the ultrasound. An important difference here between diagnostic mammogram and screening is that during the diagnostic mammograms, the interpreting radiologist is present to read the images while the patient is still in the department and to order further imaging as needed to be done in the same day, as opposed to the screening mammogram, where it is done in an outpatient setting and usually read later or the following day. If needed, the patient will be called back a different day to perform additional imaging. Our main focus today will be the screening mammogram report for average risk women. So here's the sample of the standard screening report. This is a routine report that you might see on your MyChart application. Okay. So let's go through this and try to make sense of it. We'll start with the first sentence here, with the breast composition. Okay. The breast composition, or the breast density, depends on the combination of fatty tissue, which appears dark on a mammogram, and glandular tissue, which is the white part of the mammogram. So any tissue would appear white. Okay, so the dark part is the fatty tissue, and the white part is the dense tissue, the stromal tissue, or the glandular tissue. So any tissue that is not fat will appear white, including cancer. Breast density is divided into 4 types. First, it's almost entirely fatty. That means more than 75% of the breast tissue is fat, and it appears more dark. Second is scattered fibroglandular tissue, where we have mixed tissue of fat and glandular tissue. But it remains mostly fat, mostly dark. Third is the heterogeneously dense parenchyma, and it has less fat and more white tissue, so less than 50% of fatty tissue. And then finally, the extremely dense parenchyma. And this is mostly 75% of it is white, that means glandular tissue, and 25% or less is fat. So 50% of the women have dense breast tissue, either heterogeneously dense or extremely dense, 10% in extremely dense category and approximately 40% in heterogeneously dense category. Breast density decreases with age. So younger women usually have denser breasts, but then they slowly become more fatty. Now, to better explain why breast density is important to mention in the report and important for you to know your own breast density. We have here a screening mammogram of a 53-year-old female. Her breast is almost entirely fatty, more dark than white. And here we see a small clumped area of whiteness, basically. So to make it a bit larger, here it is again, we see it. And yeah, this is a mass, a tumor within the breast. Now, it's easily seen because it's just white in the background of dark tissue, fatty tissue. Fortunately, it was detected on a screening mammogram. That means the patient did not have any symptoms, she did not feel any lumps, and it was biopsied, proven breast cancer in its early stages. Okay. So to compare with another breast, now here's a breast with more denser composition, heterogeneously dense. This is a normal mammogram of a dense tissue, it has been completely worked up, and we're sure it's normal. But just to illustrate my point, if I add this lesion to the breast, if we go back, now see where I've added here. There it is. It's very hard to detect that small white mass in the background of dense breast tissue. So that's why it's important to be aware of your own breast density. By itself, dense breast is a risk factor to develop breast cancer, not only because it lowers the detection rate, but just because of increased glandular tissue. Okay. And here we do stress the point of getting regular annual screening mammograms, because this mass, although when we first detected it, it was small, it was about 5 millimeters. If it wasn't seen in the dense breast tissue, that wasn't seen in the this year's mammogram, getting another mammogram in another year, this would have increased, not by that much, but it would have changed in size. And when we compare it to the previous, we would be able, hopefully, to pick it up. So even if it doubles in size, even if this 5 millimeter mass becomes a 1 centimeter mass, if we do detect it and biopsy it, it would be still in the earlier stages. Okay, this is an example of the 3D mammogram that I talked about versus the 2D mammogram. So 3D mammogram, basically we look at the breast tissue in layers. It helps us view the lesions more clearer. Okay. So back to the mammogram report. Here we'll go to the second line. No suspicious masses, microcalcifications, or architectural distortion. Okay. So no suspicious masses. Not all masses are suspicious. Not all masses are cancerous. We look at each mass separately and evaluate it, depending on its shape and borders. So benign features would include the shape, usually oval shaped with circumscribed sharp borders. Here, if I draw the if I get a pencil and draw the borders of this mass, here it can be easily drawn and it would be very sharp. These are benign features. Now comparing it to the more suspicious features, it usually is round rather than oval, and oftentimes irregular margins, such as we see here. Okay. Whenever we do see a mass, we bring the patient back to perform additional images, usually spot compression views, where we compress the breast at that certain location. It helps spread out the surrounding tissue and makes the mass more visible, and we can see the margins clearer. After we've seen it, we have established that it really is a real lesion, a real mass, we go on to perform ultrasound. And this is the same mass that was done before. We saw it on ultrasound and we biopsied it under ultrasound guidance. Okay. So here's another case illustrating the spot compression views with demonstrating a mass with irregular margins. And here it is on ultrasound. Okay. This was also biopsied and turned out to be cancer. Okay. And now we'll go to another mass here. This is a screening mammogram with dense breast, and we see this oval lesion, and it's better detected by a 3D ultrasound, 3D mammogram, sorry. And again, it's an oval mass with sharp borders, clearly benign features. We go for ultrasound, and it turns out to be a cyst. Completely benign. We don't need to follow it up. We can reassure the patient, and we'll see her next year. Okay. Now moving on to architectural distortion. So as its name implies, the the architectural composition of the breast or the shape of the breast tissue is distorted. It's irregular. Here we see this area of distortion better appreciated on the 3D mammogram. We don't really see a clear mass, not a clear density, not like we saw on the images before. But it is suspicious enough for us to call the patient back. We can do spot compression views and ultrasound. So here we did ultrasound, and we were able to see this. So there's this clear mass seen by ultrasound that was just hiding between the area of irregularity, not clearly seen on mammogram, but definitely on ultrasound. We biopsied it as well, and this turned out to be cancer. Okay, another case. Here we see it's a scattered fibroglandular tissue. We see this area of, again, slight irregularity, a little bit more denser than the rest of the tissue. So we called this patient back, and we did a spot compression view, both in 2D and 3D. And then here it spreads the tissue again. We're not seeing it as clearly as it was on before. It's not as dense. So this turned out to be just overlapping breast tissue. Not all distortions are real distortions. Oftentimes they're just overlapping breast tissue, and that's why we need proper compression to spread the tissue out. This is another case of overlapping tissue. We see these areas of distortion, and then when we call the patient back, do spot compression views, they completely spread out, they completely disappear, and this is just overlapping normal breast tissue. Okay, moving on to calcification. Calcifications in the breast is very common, and they do tend to increase as the patient gets older. We have, again, benign features and suspicious features for calcifications. Benign calcifications are usually diffuse within the same breast. It's scattered throughout the breast, or they can be loosely grouped. They're usually larger, usually round, or could be rod-like. So easily seen by mammogram. Versus the suspicious calcifications, they're more tightly grouped or could be in a segmental, kind of like a triangular shaped distribution or a linear distribution. They often are amorphous, which really no distinct shape, or pleomorphic, and that's basically different shapes of the calcifications within the same region. They can also be linear or branching. These are all suspicious features for the calcifications. Now, the suspicious calcifications are harder to see on mammogram versus the benign calcifications where they're clearly seen. They're diffused throughout the whole breast. They're seen bilaterally in both breasts. So this, we just reassure the patient there's nothing wrong, and we categorize it as normal screening mammogram or benign screening mammogram. So this is another case, another example of benign calcifications. Here we see these coarse calcifications. It's basically around the vessel. This is vascular calcifications, basically atherosclerosis, and they're seen in older patients, diabetic patients. Another example is these calcifications. They're loosely grouped, not tightly grouped. They're large, and they're pretty much benign. So suspicious microcalcifications, when we do see them, they're, as I said, they're very hard to detect. So we often call the patient back to do magnification views. Magnification views are similar to compression views. We compress on that same area and magnify it to better assess the shape of the microcalcifications. Ultrasound is not usually necessary. Calcifications are not usually seen by ultrasound, but we often, if we do see suspicious calcifications, we may ask the patient to come back for ultrasound just to make sure the rest of the breast is normal and no other suspicious features. So Here we have a small group of microcalcifications. There it is on the 2D mammogram, and it's better seen on the 3D mammogram, again, because we go through layers of breast tissue. It's tightly grouped, as you see, and there it is. Okay. So we call the patient back for magnification views, and here it is, clearly tightly grouped microcalcifications of different shapes, irregular, some of which are branching, all suspicious features. We did an ultrasound for this patient, and we were not able to see these microcalcifications by ultrasound. We did not see any other masses or other lesions. So we ended up biopsying these microcalcifications under mammography. And it turned out to be an earlier stage, or one of the earliest stages of breast cancer, limited to the ducts and no invasion into the surrounding breast tissue. Okay, and here we pause to reiterate the importance of mammography. These calcifications in its earlier stages are only seen by mammogram. We would not be able to see them by ultrasound or MRI. So even when patients request to be screened by ultrasound, we try to explain the mammogram that is necessary to better detect these earlier stages. We don't usually refuse them, but we try to persuade them into having the mammogram. Okay, this is another case of microcalcifications. Again, different shapes, and it's associated here in this case with a small density, a small mass. Also biopsy-proven cancer. Okay, now moving to our final section in the mammogram report, the impression and recommendations. Okay, so the impression is basically a brief summary of our findings at the mammogram. We often rely on the BIRADS description. BIRADS stands for breast imaging and breast imaging reporting and data system. So this is a standardized method to uniform the mammogram report across the hospitals and in most countries. We have 7 categories of BIRADS, and here, so for us, for our topic, the screening mammogram, we usually use the first 3, so 0, 1, and 2. So if we go to 1 and 2, BIRADS 1 and 2, these are either negative, we don't see anything, or what we see is benign findings, benign calcifications, or stable benign masses. Okay. And we just recommend that the patient come back next year to do her follow-up, her screening mammogram. Okay, now we'll go back to category 0. This means that we need further imaging. The screening mammogram is incomplete at this point. So further imaging, like we said, could be magnification or spot compression views or ultrasound. And after recommending this, then the patient will be called back for a diagnostic mammogram. It is no longer a screening mammogram, it is diagnostic. And when we do these additional imaging, we will then come to a conclusion and give another BIRADS category. So if everything looks fine, everything is benign, not worrisome, we'll go back to given 1 or 2, BIRADS category 1 or 2. But if we do see something, depends on the level of suspicion, then we'll go down to giving the patient BIRADS categories ranging from 3 to 6. So here I'm not going to go into too much detail, but just quickly say that BIRADS 3, if it's most likely benign, chances of being a benign finding is more than 98%, then we would just recommend that the patient comes back every 6 months for a period of 2 years to document the stability of the findings over a 2-year period. Now, BIRADS category 4 is a higher suspicion for breast cancer than the category 3, but it is a wide range. It ranges from 3% to 94% suspicion of breast cancer. But either way, we recommend a biopsy. BIRADS 5 is very suspicious. The chance of being a cancer is more than 95%, and this is a definite biopsy. BIRADS 6 is only done for those patients who are biopsy-proven breast cancer. They've gone through all of the necessary tests, the biopsies, and it's just basically when they have their mammogram to see the treatment, how the treatment is going, to see the response of the cancer through treatment. Then we just give them a BIRADS category 6. Okay, so we're almost done here. Just a few key points regarding screening mammogram. So as we said, and hopefully demonstrated, mammogram is the golden standard for screening of breast cancer. Screening causes anxiety, which naturally, I mean, we're looking for breast cancer. But hopefully, if you keep in mind that the aim is early detection and early treatment, it's more successful treatment, then that may ease the level of anxiety. Compression is a must, unfortunately. We know that it's uncomfortable, that it's painful, but it's really necessary to spread the breast tissue, and that makes it easier for us to look for the lesions. Okay, so some key points about the BIRADS 0 category, the callbacks basically. So this is very common. Up to 15% of the mammograms that we do are called back for extra views. This is more common in dense breasts, particularly if there's no previous mammograms to compare with. And here we would stress the point of compliance to yearly mammograms. So in order for us to compare it with what we have previously and judge any changes that are happening and investigate that accordingly. So callbacks obviously will cause more anxiety, but if you remember that not all callbacks are cancer. In fact, less than 0.1% of the callbacks cases, or that means 1 in 10 women who are called back end up having cancer. The majority of the callbacks end up being normal breast tissue or benign findings. Usually, oftentimes, it's just overlapping breast tissue. And here we emphasize the importance of compression, proper compression. Okay. And then finally, we come to the end. Just remind you that early detection saves lives. Thank you. And don't forget to book your screening mammogram.